In 2018, the FDA issued uh, a pretty stark, highly publicized warning against using vaginal lasers.
Yeah, it made major waves in the medical community.
Right. Because they were citing these rare but really severe complications. Things like scarring and chronic pain.
Which is obviously terrifying for anyone considering the treatment.
Exactly. But here is where it gets interesting for you, the listener. Because if you look at the clinical data just a few years later, you'll find leading medical professionals combining those exact same lasers with autologous blood plasma.
Right, they're using it to create one of the most effective regenerative treatments we have for severe tissue atrophy.
So how did a flag device become like the cornerstone of this highly sought-after clinical protocol?
It's a huge turnaround.
It really is. So welcome to today's deep dive. If you track the rapidly advancing and honestly sometimes controversial space of regenerative medicine, you are absolutely in the right place today.
We've got a lot of ground to cover.
We do. We are taking a whole stack of clinical sources, trial data, histological studies, all to dissect two heavy hitters in this field, the fractional CO2 laser and the O-shot.
But we aren't just looking at them in isolation, right?
No, exactly. Because treating them in isolation kind of misses the most compelling part of the science here.
I'd argue the real breakthrough in the literature right now is the synergy, is what happens between these two completely different mechanisms of action. We are looking at what actually happens when you intentionally stack thermal energy and biological growth factors.
Which brings us to the core mission for today. The specific question we're going to answer for you, based on the actual clinical protocols of this. Right. What is the recommended clinical interval between a fractional CO2 laser session and an O-shot treatment?
That's the million-dollar question.
Right. If a clinician is going to utilize both, how exactly are they timing it to maximize that cellular response?
Well, to understand the timing, we really have to break down the microscopic environment first.
Because we're talking about two fundamentally different pathways to tissue regeneration here.
Entirely different. Let's start with the laser side of the equation.
Okay, so we see devices like Femilift, Monalisa Touch, CO2 RE Intima mentioned all over the clinical literature.
Right.
These are all fractional CO2 lasers. So walk us through the actual physics of what they are doing to the mucosal tissue. Like, what's happening?
Sure. So the defining characteristic of a CO2 laser is its wavelength. It's typically right around 10,600 nanometers.
Okay.
And at that specific wavelength, the electromagnetic energy is incredibly well absorbed by water.
And the vaginal mucosa is obviously highly hydrated tissue.
Exactly. So when that laser fires, the intracellular water essentially absorbs all that energy instantly, flashes to steam, and causes this highly localized vaporization of the target cells.
Oh, wow. So it's essentially flash boiling the tissue at a microscopic level.
Yeah, to force a response. And the precision is just remarkable.
Right, because they aren't just burning everything indiscriminately.
No, not at all. The sources highlight a histological study by Dr. Elizabeth Hurleman and her colleagues. They actually took biopsies to observe this exact process in vivo.
Which is fascinating.
It is. And they found that these fractional lasers create highly precise microscopic columns of thermal injury. They call them zones of ablation.
Right.
And they are strictly 800 to 900 microns in diameter.
I mean, so less than a millimeter wide.
Exactly, less than a millimeter. And surrounding each of those vaporized columns is a narrow zone of coagulated tissue.
Okay.
And that specific thermal signature, that microinjury, that is the catalyst.
Because the local cells detect that thermal trauma and immediately sound the alarm, right?
Yep. They upregulate the production of heat shock proteins. This triggers the acute inflammatory phase of the wound healing cascade.
Signaling all the fibroblasts to just flood the area.
You got it.
And a fibroblast, they're the primary engines of remodeling. They lay down new type 3 collagen, which eventually matures into that stronger type I collagen, plus elastin. So in a way, the thermal energy is basically tricking the tissue into a state of emergency repair.
That's a great way to put it. Yes.
Okay, so now if we pivot to the biological side, the O-shot, or PRP, we're completely abandoning that thermal destruction, right?
We are. It's a totally different game.
We're relying strictly on autologous cellular signaling.
Right. So for the O-shot, the provider draws the patient's blood, runs it through a centrifuge to isolate the platelet-rich plasma.
The PRP?
Yeah, the PRP. And then they inject that concentrate directly into the clitoral and upper vaginal areas, But the critical mechanism here isn't just the volume of the fluid.
Right.
It's what happens when those platelets degranulate.
Because platelets are packed with alpha granules, right?
Mm-hmm.
And when they activate in the tissue, they dump massive amounts of highly specific growth factors directly into the extracellular matrix.
Exactly. Massive amounts. The sources mention at least 7 key identified growth factors.
Including VEGF, right? Vascular endothelial growth factor.
Yes. And VEGF specifically drives angiogenesis, the formation of new blood vessels.
Okay, so that's the biological payload.
Right. While the laser is coursing structural remodeling through, controlled trauma, the PRP is delivering this massive concentration of VEGF, PDGF, and TGF-beta.
To directly stimulate unipotent stem cells and enhance local vascularity.
And regenerate nerve endings, too.
Wow. Okay, I'm trying to visualize how these two actually interact, because you hear that old analogy of aerating the soil for fertilizer.
Right, right.
But that feels a bit too passive for what is actually happening at the cellular level here.
It's a little simplistic, yeah.
It sounds more like an aggressive architectural retrofit to me. Like, if the tissue is a building, the laser is the demolition crew.
Okay, I like this.
It's removing weakened structural columns and setting off the fire alarms to summon the emergency repair teams.
Yeah.
And then the PRP injection is like airdropping a massive supply of high-grade raw materials and like architectural foremen directly into the disaster zone.
To ensure the new structure is built back exponentially stronger than the original.
Exactly.
That is a much more accurate representation of the cellular dynamics. The thermal injury creates the demand, and the biological injection supplies the specialized regenerative capacity.
So the laser is your structural catalyst, and the PRP is your biological accelerator.
Perfectly said.
Which brings us back to the core clinical question of this whole deep dive.
Yeah.
If we have the demolition phase and the biological rebuild phase, how are clinicians timing this?
The interval.
Right. Because logically, you'd think there should be a delay. You'd want to let that acute thermal inflammation subside before introducing needle trauma and the plasma volume of an O shock.
You would think so.
So what is the recommended clinical interval? Do they wait a week? A month?
The data dictates the exact opposite of what you might expect.
Oh, really?
Yeah. The recommended interval found uniformly across the clinical protocols is 0.
Wait, 0?
0. There is no waiting period whatsoever.
None. So the acute inflammation is actually the goal.
Precisely. In the clinical protocol, which is often referred to as LEO, or laser-enhanced O-shot, the O-shot is administered immediately after the very first session of the fractional CO2 laser.
Wow.
The patient never even leaves the treatment room.
Okay, let's look at the logistics of that appointment then, because stacking these treatments has to require some intense clinical choreography.
It's highly streamlined. It all happens in a single hour.
Just 1 hour.
Yeah. The patient arrives, and the initial blood draw is performed right away so the centrifuge can run the separation cycles.
Okay.
And while the PRP is being prepped, the laser treatment begins. The ablative portion takes roughly maybe 15 to 20 minutes.
And what does that feel like?
Patients usually report a warming sensation, but the pain is typically negligible.
Right.
Then immediately following the laser extraction, the freshly concentrated PRP is drawn into syringes and injected into the targeted mucosa and clitoral complex.
And how long does that injection phase take?
About 30 minutes.
Okay, wait. I have to push back here on behalf of the listener, just regarding the reality of that patient experience.
Sure.
We are talking about stacking thermal ablation and needle injections back to back in a single hour in one of the most highly innervated mucosal areas of the human body.
It sounds intense.
Physiologically, doesn't that induce just an overwhelming pain response? Like, why subject the patient to both simultaneously rather than spacing them out by a few weeks?
It's a fair question, but the pain management is actually quite robust.
Oh, they numb it.
Heavily. Strong topical anesthetics are applied prior to any injections, and many clinics utilize medical nitrous oxide nitronox to modulate the central nervous system's perception of pain and anxiety during the procedure.
Okay, that makes sense.
But to answer your question about why they don't space it out, it comes down to those physical microchannels we discussed earlier.
The 800 micron columns of ablation.
Yes. When the CO2 laser vaporizes those columns, it is literally punching physical conduits deep into the lamina propria.
Right, tiny holes all over the tissue.
Exactly. And if you wait even a few days, the tissue's natural epithelialization process will seal those columns shut.
They'll heal over.
Right. But by injecting the PRP immediately, the growth factors can physically diffuse through those open microchannels.
Oh, wow.
It achieves a far deeper and more uniform distribution throughout the vaginal walls than an injection alone could ever achieve.
That makes total sense.
Yeah.
So you are utilizing the acute thermal trauma not just as an inflammatory trigger, but as an actual physical delivery mechanism for the plasma.
Yes, before the tissue can coagulate and close the doors.
So the heat primes the cell receptors and the channels deliver the payload.
Exactly. Spacing the treatments out means completely missing that critical window of heightened cellular receptivity and physical permeability.
Okay, so we established the interval is immediate. That brings up the obvious next phase, recovery.
Right.
Because while the procedure happens in a 1-hour window, the physiological recovery has to be complicated by stacking thermal and biological modalities.
It is. The downtime rules are very strict, and it's a critical distinction you'll see in the clinical literature.
Because if a patient receives an isolated O shot, just the PRP injection, there's practically zero downtime.
Exactly. The biological injection doesn't compromise the structural integrity of the mucosa, so normal activities can resume immediately.
Even intimate activities.
Yep, same day. But the LEO protocol changes the parameters entirely.
Because of the thermal ablation from the laser, you've introduced a microscopic crust at the surface level that needs time to heal.
Right. When the CO2 laser is integrated, patients are placed under a strict 72-hour restriction.
So 3 days.
Yes. No vigorous exercise, heavy lifting, or intimate activity for 3 full nights.
And that 72 hours, that's just the standard biological window for initial epithelialization, right?
Exactly.
You basically need those 3 days for the surface mucosa to seal over the thermal injuries. Friction or tension on that tissue too early could shear the delicate new cellular matrix.
Which risks infection or scarring. That's the exact rationale. You have to protect the integrity of the womb healing cascade while those heat shock proteins are doing their initial work.
Okay, so the initial recovery is 3 days. But the timeline for the actual clinical results is vastly different, isn't it?
Oh yeah, completely different.
Because we are dealing with regenerative angiogenesis and collagen synthesis. This isn't a synthetic filler. The tissue isn't instantly plumped.
No, not at all. The timeline is highly progressive.
How progressive?
Well, the sources indicate that while some patients might notice an initial reduction in dryness or maybe a slight bump in sensitivity within the first few weeks, the deep cellular remodeling takes time.
Right. Building new blood vessels isn't an overnight process.
Exactly. Neovascularization, the sprouting of new capillary networks from the VEGF, and the maturation of collagen type 3 into type I, that all requires about 3 to 4 months to reach absolute peak efficacy.
Wow. So it requires some serious physiological patience.
Yeah. It does. But once that new extracellular matrix is established, the clinical benefits typically sustained for 12 to 18 months.
Which is a long time in regenerative terms.
It is, and standard protocols recommend an annual maintenance session to outpace the natural, ongoing cellular aging process.
Okay, what I find most compelling in all this data is how this combination physically addresses the anatomy.
To layering.
Yes. The literature clearly breaks down this distinct 3-layer biological benefit when the LEO protocol is fully actualized.
And that stratified approach is really the hallmark of combining the modalities. Let's look at the surface layer first, the epithelium.
Okay.
The thermal and biological stimulation drives cellular turnover, which restores the mucosal thickness.
And that naturally increases glycogen production, right?
Yep. Which feeds the local lactobacilli.
Helping to restabilize the acidic pH of the microbiome.
While simultaneously heightening nerve ending sensitivity.
So the surface layer is all about restoring the biochemical environment and combating the extreme dryness and friction. Then you move deeper, right? To the middle layer, the lamina propria.
Right, and this is the domain of the fibroblasts. The treatment forces a massive shift in the elastin and collagen ratios here.
So by repopulating the extracellular matrix, you restore the mechanical elasticity and structural firmness of the vaginal walls.
Things that typically degrade as estrogen levels plummet.
Right, which naturally cascades into the third deepest layer, the endopelvic fascia.
And this is where it gets really interesting.
Because this is where the procedure crosses from treating, sexual function into treating deeper physiological mechanics.
Correct. By driving collagen synthesis all the way down into the deep supporting tissues and fascia, the treatment reinforces the mechanical hammock that supports the pelvic organs.
Right.
And this deep structural regeneration is exactly why the clinical data shows such a significant reduction in mild stress urinary incontinence.
Like leaking when coughing or laughing. You are literally rebuilding the scaffolding that supports the urethra.
It's an incredibly comprehensive, multi-layered physiological overhaul.
It is. But this brings us to the necessary friction in today's deep dive.
The controversy.
Yeah. Altering tissue at this depth, using ablative energy, naturally attracts intense regulatory scrutiny.
Of course.
We cannot look at this impressive clinical data without confronting the broader medical controversies surrounding these devices.
It's impossible to discuss energy-based mucosal treatments without addressing the 2018 FDA action.
Right, because the FDA issued a very specific, stark warning against the use of these lasers for vaginal rejuvenation.
They did.
They cited adverse event reports detailing severe burning, intractable chronic pain, and agglutination, where the thermal injury actually causes the tissue surfaces to heal fused together.
Which is a severe complication.
They effectively warned the industry that these devices were not clear for cosmetic rejuvenation and demanded an immediate halt to that specific marketing.
It was a massive inflection point for the field. But the subsequent reaction from the clinical and research community is where the nuance really lives.
How so?
Well, if you look at the comprehensive 2020 review published by Guaro and colleagues, they aggressively critiqued the FDA's methodology in that warning.
They basically argued the FDA committed a massive category error. Right?
A profound one. Gua et al. Pointed out that the FDA deliberately conflated elective aesthetic procedures like cosmetic bleaching or tightening for purely visual reasons with the medical treatment of genitourinary syndrome of menopause, or GSM.
And the distinction between those two is critical.
Completely different things.
Because GSM isn't a cosmetic insecurity. It's a severe progressive condition involving profound tissue atrophy, extreme dryness, and debilitating dyspareunia, painful intercourse.
Exactly. The researchers essentially argued that you cannot apply the same risk-benefit ratio to a patient seeking a cosmetic alteration as you do to a postmenopausal woman whose tissue has degraded to the point where normal function causes lacerations and severe pain.
The baseline tissue state is entirely different.
Exactly. So the urogynecology community pushed back and demanded we look at the actual controlled trial data.
And what did that show?
Well, the standout here is the 2018 study by Cruz et al., because it was double-blind and placebo-controlled.
Which stripped away the subjective placebo effect that heavily influences pain and sexual function studies.
Yep. And the data held up beautifully. Cruz et al. Demonstrated that the fractional CO2 laser provided statistically significant improvements in GSM symptoms, particularly dyspareunia.
And what about the safety?
It had a highly favorable safety profile when executed by specialized providers.
But the real stress test for the laser was the Velviat trial, which is heavily cited in all our sources for today.
Oh, the Velviat trial is fascinating.
Because they didn't just test the laser against a placebo, they pitted it directly against the pharmaceutical gold standard.
Prescription vaginal estrogen cream.
Right. And going into that data, you would intuitively expect the targeted hormone replacement to just drastically outperform the laser's thermal trauma in treating an estrogen deficiency condition.
That was definitely the assumption. But the 6-month metrics told a completely different story.
They did.
When evaluating the vaginal health index and patient-reported symptom severity, the Velvet trial found that the fractional CO2 laser and the localized estrogen cream resulted in similar, highly significant clinical improvements.
They effectively went toe-to-toe.
He tied.
Which completely validates the LEO protocol's foundational logic when you think about it. If the laser alone can match pharmaceutical estrogen, stacking it with the regenerative power of a PRP autologous graft explains the intense clinical adoption, despite the FDA's initial broadside.
Exactly. Leading urogynecology societies reviewed the totality of the data, including those adverse event databases, and concluded that while severe complications like agglutination and scarring are realities of ablative energy, they are statistically infrequent. The safety profile is fundamentally dictated by patient selection and provider expertise.
It requires a highly compromised baseline like severe GSM to justify the introduction of thermal trauma.
Right, you don't use it lightly.
But because the risk of thermal injury is non-zero, the scientific community is already engineering the next iteration.
They are.
The sources indicate a massive shift toward non-ablative technologies.
Which is just the logical evolutionary step. I mean, if the thermal vaporization of the CO2 laser is a primary risk factor for scarring, how do we trigger cellular regeneration without destroying the surface tissue?
And the answer lies in near-infrared lasers.
Yes. Devices like the solopelvic therapy mentioned in the text. The physics here shift completely.
Entirely, right? Because near-infrared lasers operate on a wavelength that is very poorly absorbed by water.
Exactly. So instead of hitting the intracellular water and flashing it to steam, the near-infrared energy bypasses the water completely.
It penetrates deep into the pelvic floor, musculature, and fascia without causing any vaporization or thermal destruction at the mucosal surface.
None at all.
But wait, so if it's not causing microinjuries and it's not triggering the wound healing cascade, how is it forcing the tissue to regenerate?
It utilizes a completely different biological pathway called photobiomodulation.
Which sounds incredibly sci-fi.
It really does. But the science is solid. The near-infrared photons penetrate the cells and are directly absorbed by cytochrome C oxidase.
Which is an enzyme within the mitochondria, right?
Yes. And this specific photon absorption physically accelerates the electron transport chain, resulting in a massive upregulation of ATP synthesis.
So it's essentially supercharging the cellular batteries directly,
Yes.
bypassing the need for an inflammatory catalyst altogether.
Exactly. It provides the energy for tissue repair and reduces chronic neurogenic inflammation without a single microscopic burn.
That is it's the absolute bleeding edge of pelvic floor medicine.
It really is. It offers a potentially risk-free alternative for complex, chronic pain conditions where introducing thermal trauma is just contraindicated.
Wow. We have dissected an immense amount of clinical science today, from ablative physics to mitochondrial photon absorption.
We covered a lot.
Let's pull it all back to the core mission for you, the listener. If you are analyzing the LEO protocol, combining the fractional CO2 laser with the O-shot, the recommended clinical interval is immediate.
0 wait time.
0. The biological PRP is injected straight into the mucosal tissue immediately following the 15-minute laser session, inside the exact same hour-long appointment.
Right.
This 0 wait time protocol intentionally utilizes those 800-micron thermal channels as physical conduits, allowing the autologous growth factors to diffuse deeply into the tissue.
Targeting the surface mucosa, the collagen-rich lamina propria, and the deep endopelvic fascia, all before the acute inflammatory window closes.
It perfectly illustrates how regenerative medicine is learning to manipulate our physiological timing to stack therapeutic outcomes.
It really does.
And it leaves me with a final thought for you to consider as we close out today. We spent this deep dive exploring how drawing your own blood plasma, isolating its growth factors, and using a laser's thermal physics to deliver it deep into degrading tissue can literally rebuild anatomical scaffolding and match the efficacy of pharmaceutical hormones.
Yeah.
As photobiomodulation and autologous cellular therapies continue to advance, it points to a fascinating paradigm shift in how we approach the biology of aging.
It's total shift.
How far are we from a medical reality where we entirely abandon external synthesized pharmaceuticals and instead rely exclusively on precision physics to command our own autologous cellular blueprints to simply rebuild what time has degraded?
That is the ultimate promise of regenerative medicine, moving away from chemical symptom management and toward active, autologous architectural repair.
A total shift from the pharmacy back to our own cellular intelligence. Thank you for joining us on this deep dive into the clinical data. Keep questioning the science, keep learning, and we'll catch you on the next one.